So somebody wanted to know about dysphotopsia. So you're probably familiar with photopsia, which is opsia C, photo means light. And so dysphotopsia means there's an abnormality in the light in an optical setting. What that means for us is that optical dysphotopsias can come to neuro-ophthalmology and mimic neuro-ophthalmic problems because the patient is complaining about either seeing something, which is a positive dysphotopsia, or something's missing in my peripheral field, that's a negative dysphotopsia. So we'd like to know, is it positive or negative? The positive ones are like glare, they see a light, a flash, and it's in the temporal periphery. And the main thing you need to make sure is that it's not an entoptic phenomenon in the eye, like vitreoretinal traction or floaters or something that's in their eye other than the intraocular lens, even though the intraocular lens is the presumptive cause of the optical dysphotopsia after cataract extraction. The cataract surgery itself is usually uncomplicated, so it's not really a complication of the procedure. It's a known adverse effect of having an intraocular lens placed after cataract extraction. And the negative dysphotopsia, the patient says that they have a field defect or a black spot or a crescent of black in their temporal field. And the main thing you need to know in terms of neuro-op is making sure that it's not the actual temporal crescent. So when you have a field defect in the way periphery like this, in the temporal field, you really can't test that field with a 24 or a 30-2, which will only be testing the central field. And so the only way to test this field in the periphery is with a Goldmann perimeter, a kinetic perimeter that tests the entire field, or with confrontation. And so you need to make sure that this isn't actually the temporal crescent. And normally it's easy because there's a close temporal relationship between the onset of the negative dysphotopsia and cataract extraction. So in the absence of cataract extraction, someone who has this temporal crescent, you need to check the pupil, because if they have an RAPD, then something's in the eye or the optic nerve producing that. Usually it's some sort of nasal retinal problem, or it's an optic neuropathy. And if there's no RAPD, that could be the temporal crescent, which is a monocular temporal crescent, because the field isn't really a circle, it's an oval. And so this temporal crescent has no correlate in the nasal portion of the fellow eye. And so that lesion is right here in the cortex in the anterior mesial portion of the occipital. So once you've made sure that it's not the monocular temporal crescent, that there's no RAPD, and that it occurred after cataract extraction, then you can make the diagnosis of the negative dysphotopsia from the IOL. And there's a number of theories about why this could occur. First, based on, number one, the design of the lens. Number two, how the lens material, whether it's silicon or some other material, PMMA, and then there's intraoperative and postoperative things that happen with the capsule that could make the optical effect called the negative dysphotopsia. And you can read more about the effects. We're just talking about how this would end up in neuro-op. So a neuro-ophthalmologist or a clinician dealing with a negative dysphotopsia, your first job is make sure it's not really a neuro-op problem. The monocular temporal crescent, or if there's an RAPD, that is not optical. Those two findings right there make it not optical. And in terms of design, there are various theories about why the lens design, a sharp edge versus a rounded edge IOL, can produce the negative dysphotopsia. And ray diagrams can demonstrate that if the incident light exceeds a critical angle, you'll get internal reflectivity, and that can produce the symptoms of the positive and negative dysphotopsia, because the angle of incidence of the light can lead to internal reflection that can produce both the positive and the negative dysphotopsia in the square edge design versus the round edge. And for materials, Acrosoft versus silicon, different risks. It turns out that a lot of patients have this, they just don't tell you about it. And the good part about it is the majority of the cases, it just goes away by itself, because you have brain neuroadaptation to the optical perception of the dysphotopsia. In the beginning, we thought maybe the pupil size might have something to do with it, because
If you have a bigger pupil, it'll hit the edge of the IOL versus a smaller pupil, it's in the optical center. But this is very controversial. However, I don't have any objection to people trying a miotic agent just to see if you can make it better. Also, the pinhole effect of having the meiosis might improve their refraction. You should definitely refract them, do corneal topography, all the usual things. Make sure it's not dry eye, do an OCT of the macula, make sure it's not entoptic from something in the eye like traction, epiretinal membrane, floaters, the usual things. And then if all that doesn't work, you did your best refraction, you tried the miotics, you could YAG the capsule. But once you do that, it's going to make a difference to surgeons on the IOL exchange. So the ultimate is to just take it out and put a new one in. So we would not normally recommend IOL exchange until we're sure that we excluded entoptic phenomenon, alternative etiologies, make sure it's not neuro-op with the temporal crescent or an RAPD. Try the little pupil, refract them, drops, dry eye, everything. And then the final step is just exchange this lens. So you need to know a little bit about positive and negative dysphotopsias and optical effect after cataract extraction related to intraocular lens placement, and whether it's lens design, lens material, the capsule, or the pupil is still a little bit controversial, but it doesn't matter because you're just going to run through the list of countermeasures. But in most cases, just go away by themselves and the patient just needs reassurance.